The blood pressure pill sitting in your medicine cabinet right now, according to researchers at the University of Virginia School of Medicine, may be slowly turning your kidney into a different organ than the one you were born with. This is not about side effects. This is not about the wrong dosage. This is not about whether you should be on a different drug. This is about a structural change happening inside the kidney itself. A change that the standard creatinine test on your annual lab work was never designed to catch. If you're over 60 and if you have been taking a blood pressure pill that ends in the letters Pril, or one that ends in Sartan, for more than 5 years, the kidney in your body right now does not look like the one in the textbook. According to a paper published as the cover article of the journal Circulation Research in October of 2024, it looks like the kidney on the right side of your screen. And that is not a metaphor. A team led by Dr. Maria Luisa Sequeira Lopez and Dr. Ariel Gomez at UVA used 3D imaging to look inside the kidneys of patients who had been on these medications for 6 years or longer. What they found was not subtle. The pipes had thickened. New nerve fibers had grown in, inflammatory cells had moved in and set up shop. The organ that was supposed to be filtering your blood had quietly retrofitted itself into something else. Something that produces a hormone called renin around the clock to compensate for the very drug you are taking. Their word for the result was Frankenstein. Their formal description, the one they used in the journal, was a pathological neuroimmune endocrine organ. The kidney is still in there. It still looks normal from the outside, but the machinery inside has been rebuilt for a different job. In the next 60 minutes, I'm going to walk you through 7 specific things. The exact mechanism of what happens inside the kidney in plain English with no jargon you have to look up. The 4 early warning signs that your standard annual lab work was not built to catch, and the 3 specific tests that catch them. The real reason your own doctor has not mentioned any of this to you yet, and why it is not because they are hiding it. The exact phrasing to use at your next appointment, the words that get a busy doctor to put down their pen and actually listen instead of dismissing you. What nephrologists are quietly doing differently right now for their patients over 60 on these drugs. The $3.2 million grant the National Institutes of Health just awarded UVA in April of this year to extend this research and what it means for you. And finally, the one identity shift that by the end of this video will change how every appointment you ever have from this day forward unfolds. By the way, before we go any further, I have to say this one thing because the UVA researchers themselves say it in every interview. Do not stop your medication after watching this video. Do not skip a dose. Do not cut a pill in half. What we are doing here is learning something so that you can have a better conversation with your doctor. Not a quieter one, a better one. Now, let me tell you what you are doing on a Tuesday morning that nobody has thought to mention. You take a pill. It is a small pill, white usually, or yellow. It has been on your kitchen counter for so many years that you do not really see it anymore. You see the coffee, you see the dog, you see whatever is on the radio. The pill goes in with the orange juice, and you do not think about it again until tomorrow morning. And every 6 months or every year, you sit in a chair and they squeeze your arm and the number's fine. The cuff says you are doing what you are supposed to be doing. The doctor nods. They write the renewal, you leave. You feel okay about it because the number was okay. The number has been okay for a long time, maybe 7 years, maybe 12. For some of you watching this, maybe closer to 20. The number has been the friend you trust. The number has told you over and over that the plan is working. And still, inside your body, while the number was being friendly on the surface, something else was happening to the organ that does not get measured by the cuff on your arm. Something the cuff was never designed to see. Something your own annual creatinine test, the one tucked into the standard panel your doctor orders, was not really built to catch until it had already happened. The cuff number is fine. That is what makes this so quiet. That is what makes it so easy to miss. That is what makes the discovery from UVA so important, because for the first time, someone went and looked inside the organ instead of just reading the number on the outside. So if you are sitting there right now wondering whether the plan really has been working, the honest answer is this. The cuff has been telling you one story. The kidney has been telling you another, and only one of those stories has been on your chart. The question you are now sitting with, whether you have put it into words yet or not, is the question this video exists to answer. Not, is my doctor wrong? Not, should I quit my pill? The question is, what is going on inside my kidney that nobody has been checking for, and what do I do about it? That is what we are doing here. By the end of the next hour, you will not be a patient sitting in the chair waiting for someone else to tell you what your body is doing. You will be the person at the table who already knows. Before I take you inside the UVA lab, I want to sort something out because the people watching this video are not all in the same place. There are 3 of you roughly. The first of you is the one whose creatinine number has been creeping up over the last few years. Not enough to set off any alarms. It was 1.0, then it was 1.1, then 1.2, and last visit it was 1.3. Your doctor said it was age. Your doctor said it was normal. Your doctor moved on. You felt the small jump in your chest when you read the number on the printout and you wondered what your doctor was not saying. You are the one who has been collecting small clues for a while now. The second of you is the one whose creatinine number is fine. Pristine. Your labs come back and everything is in range and your doctor says you are doing great. But something else has changed. You get up at night more than you used to. Your ankles do not look the way they used to look. You feel a tiredness that is not the tiredness of getting older. You went looking on the internet because nobody at the office had time to look with you. You are the one whose numbers say nothing is wrong and whose body says something is. The third of you is the one with no symptoms at all. Your numbers are perfect. You feel fine. You have been on this medication for 8, 10, 12 years, and you have never had a reason to question it. You're watching this video because someone in your family sent it to you, or because the title caught your eye, or because you have started to wonder lately how many of the pills on your counter you actually still need. All 3 of you are about to learn the same thing. Because the UVA research, which I'm about to walk you through, does not care which of the 3 you are. The structural change happens quietly in all 3 groups. The warning signs hide differently in each, and the conversation you need to have with your doctor is the same for all 3 of you, with different opening lines. Let me show you what they found. Sometime in the early 2010s, in a building called MR4 on Lane Road in Charlottesville, Virginia, Dr. Maria Luisa Sequeira Lopez and Dr. Ariel Gomez began asking a question that nobody else was asking out loud. The question was simple. We have been prescribing this class of blood pressure medication, the renin-angiotensin system inhibitors, the ones that end in Pril and Sartan, to tens of millions of people for 30 years. We know what the cuff number does. We know what the heart does. But what does the kidney look like on the inside in the people who have been on these drugs the longest? They started with mice. 6 months of daily treatment with an ACE inhibitor called captopril. When they looked at the kidneys under the microscope, they saw something they did not expect. The small arteries inside the kidney had thickened, not a little, a lot. The cells that were supposed to be producing renin had multiplied, spread, and changed shape entirely. They had stopped behaving like the quiet endocrine cells they were born to be. They had become what the researchers, choosing their words carefully in the formal scientific language, called invasive matrix secretory. They had moved into the walls of the blood vessels and were producing material that was making those walls thicker and thicker. But mice are mice. The team knew that what mattered was whether the same thing happens in human kidneys. So they did the harder study. They went through the kidney biopsy registry. They found 6 patients who had been taking an ACE inhibitor or an ARB for 6 years or longer and who had needed a kidney biopsy for an unrelated reason. They found 6 more patients of the same age range with the same blood pressure problem who had never been on one of these drugs. And they found 4 healthy donors as controls. 16 people, real tissue, sitting in slides in a pathology archive in Charlottesville. When they measured the thickness of the small arteries in those biopsies, the same thing showed up. The patients who had been on the drugs the longest had measurably thicker arteriolar walls than the patients who had not. The change they had found in the mice was already present in the humans. That paper came out in 2021 in a journal called JCI Insight. But the bigger paper, the one that pulled all of this together into a single picture, came out in October of 2024 as the cover article of Circulation Research. Lead author Manako Yamaguchi, working in the same UVA lab. This is where the language gets memorable. Using a newer 3D imaging technique, the team could finally see the whole kidney in 3 dimensions instead of in flat slices. And what they saw was something nobody had described before in human medicine. The small arteries inside the kidney were not just thickened. They were now wrapped in new nerve fibers, Hyperinnervated was the word Dr. Yamaguchi used. The nerves had grown in where they were not before, and the immune system had sent in inflammatory cells, which had also moved into the area and were now living there permanently. The kidney was no longer just an organ that filters your blood. It had become, in the team's own words, a pathological neuroimmune endocrine organ. Nerves talking to immune cells, talking to hormone cells. All of them working together to push renin production up to compensate for the medication that was suppressing it from the outside. The plant is still there. The plant still has the right address. But the machinery inside the plant has been rebuilt for a different job. And here is the part that matters for the cuff on your arm. While all of this is happening, your blood pressure stays controlled. The medication is doing what it was advertised to do at the surface level. The reading on the cuff is fine, but underneath that fine reading, the small arteries that feed every single filtering unit in your kidney are getting thicker. Less blood is reaching the filters. The filters work less efficiently. And because the body is remarkable at compensating, the standard creatinine test on your annual labs does not move, sometimes for years, until the loss of filtering function has become significant. Creatinine is what is called a lagging indicator. It tells you the damage is done. It does not tell you the damage is coming. That is the discovery. That is what your doctor has not yet had time to read about, because the cover article is from October of 2024. The 2025 American Heart Association hypertension guidelines do not yet include it, and the NIH just funded the next phase of the research, a $3.2 million four-year grant in April of this year. The research is moving faster than the guidelines, which means the gap between what is known and what is being practiced is right now exactly the size of this video. So now you understand the retrofitted plant. You understand why the cuff number lies. You understand why the standard creatinine test is the wrong tool to catch this until it is too late. The next question, the one you are now asking, is the one we will answer in the second half of this hour, which is, what should I be looking for and which tests should I be asking for, and how do I bring this up at my next appointment without making my doctor feel like I am questioning their judgment? Because the question is not whether your doctor is doing their job. The question is whether the tools they were given are the right tools for what is happening inside you. Let me show you the 4 warning signs your standard annual labs were not built to catch. The first one is creatinine drift inside the normal range. This one is the most common and the most dismissed. Your creatinine last year was 0.9. This year it is 1.1. The lab printout marks it as normal because the normal range for an adult goes up to around 1.2 or 1.3 depending on the lab. Your doctor sees the printout, sees that it is in range, and moves on. What gets missed is the slope. A jump of 0.2 in a single year, even inside the normal range, can represent a 15 to 20% loss of kidney filtration inside the normal range without any flag. The second is the protein that should not be there. Your kidney's filtering units, the glomeruli, are supposed to keep large protein molecules in your blood and let only small waste molecules out into your urine. When the small arteries feeding the glomeruli get thicker and less blood gets through, the filters start to leak. Tiny amounts of a protein called albumin start showing up in your urine. The amount is small enough that the standard urine dipstick at your annual physical does not always catch it. It needs a specific test called the urinary albumin to creatinine ratio, abbreviated as UACR, and it is not always ordered automatically. If it is not on your last lab printout by name, it was probably not done. The third is the rise in your blood pressure pill dose without anyone questioning why. This one is the most quietly diagnostic. If your dose has been increased over the years, or if a second blood pressure pill has been added on top of the first one, or if a third has been added on top of the second, something is making it harder for your body to control your blood pressure, and the standard response is to add more medication. But the UVA research suggests that one of the things making it harder may be the medication itself, because the kidney's compensatory response to RAS inhibition is to produce more renin, which over time pushes your body to need more drug to hold the cuff number where it was. The pattern of escalating dose is a clue, not a coincidence. The fourth is the symptom cluster that gets blamed on age. More trips to the bathroom at night, ankle swelling that comes and goes, a tiredness that is not the tiredness of having walked more than usual, a slight bitter taste at the back of the mouth in the morning, None of these on their own mean anything. All of them together in someone over 60 who has been on a Pril or a Sartan for years are the kidney sending up signals that something is changing. The signals get blamed on age because statistically that is what they almost always are. But statistically and individually are not the same thing. These 4 signs in combination are what the research is now telling us to watch for in the long-term RAS inhibitor patient. And here is what I want you to do right now before we go any further, because this is one of the 2 moments in this video where I am going to ask you to do something with your body. Pause for a second. Get the paper from your last annual physical, the lab results printout. It is probably in a drawer somewhere or in your patient portal on your phone. Find your creatinine number from this year and find it from last year and find it from 2 years ago. 3 data points. That is all you need. If those 3 numbers have moved upward, even by tenths, even while staying inside the normal range, you have a piece of information for your next appointment that is more valuable than any number in isolation. Write the 3 numbers down. We are going to use them in the second half of this hour. The question you are sitting with now, after everything you just learned in the first half of this hour, is one that almost every viewer who has gotten this far has had cross their mind at least once already. And the question is this: if this research came out in October of 2024 and the human biopsy data has been published since 2021, why has my own doctor never said a word about any of this to me? I want to answer that question carefully, because the wrong answer would be the easy answer. And the easy answer would be that your doctor is hiding something from you, or that doctors are bad, or that the system is corrupt. None of those are true. And if I told you they were, you would walk out of this video angry and primed to fight with the next person in a white coat, and that is not what is going to help you. The real answer is harder and quieter and more useful. Your doctor is running on a pattern. I do not mean that as an insult. I mean it as a structural description of how medicine actually works at the appointment level for a person over 60. Let me show you what I mean. A primary care doctor in the United States sees somewhere between 1,800 and 2,500 patients a year. They see roughly 20 to 30 patients a day in appointment slots that average 15 to 17 minutes, including the chart work afterward. Inside those 15 minutes, they have to take your history, look at your numbers, ask the standard questions, listen for anything unusual, refill what needs refilling, decide what needs ordering, and write everything down in a way that satisfies the insurance company and the electronic record system at the same time. The only way to do that job year after year, decade after decade, is to develop a pattern. A mental shortcut for what a 67-year-old patient on a Pril with a controlled cuff number and a creatinine in range looks like. The pattern says this person is doing fine. The pattern says refill the prescription. The pattern says come back in 6 months. The pattern is right, statistically, almost all of the time. The pattern is how the doctor gets through the day without making a mistake. But the pattern was built on what we knew in 2010. The pattern was built on the guidelines from 2017. The pattern is updated when the major medical societies update their official recommendations, and not before. The 2025 American Heart Association guideline for the management of high blood pressure in adults was published last year. I have looked at it. The UVA finding from 2024 is not in it. The guidance for monitoring patients on long-term ACE inhibitors and ARBs still says what it has said for years. Annual creatinine, annual potassium, cuff check, renew the prescription. That is the pattern. The new research has not yet earned its way into the pattern. It will eventually. The $3.2 million NIH grant that Dr. Gomez and Dr. Sequeira Lopez received in April of this year is funding the next 4 years of work that will be the bridge between the discovery and the guideline change. But 4 years is 4 years. And in the meantime, your doctor is doing what their training and their guidelines and their 15 minutes tell them to do. This is not negligence. This is the lag built into how medicine moves. So when I say your doctor is running on a pattern, I am not asking you to be angry with them. I am asking you to understand that the pattern was set before the discovery existed, and that the only way the pattern gets updated for you specifically before the guidelines catch up is if someone in the room brings the new information into the appointment. The someone is you, and that is the entire reason this video exists. Not to make you afraid of your doctor, not to make you quit your pill. The reason this video exists is to give you the specific, calm, respectful, evidence-based way to bring the discovery into your next appointment so that your doctor, who is a good person doing a hard job with limited time, can step out of the pattern for the 90 seconds it takes to look at you as the individual case you actually are. Because the truth, the one that nobody in healthcare says out loud, but that every honest doctor will agree with privately, is this. The patient who walks in with one specific, well-cited, respectfully asked question gets a different appointment than the patient who walks in with general worry. The first patient gets the pattern broken for them. The second patient gets the pattern repeated. So let me show you how to be the first patient. The next time you sit in that chair, the one in the small exam room with the paper crinkling underneath you, the one with the blood pressure cuff on the wall, here is what you are going to do. You are going to bring 3 things. The first thing is the printout of your last 3 years of creatinine numbers. Not your whole lab record, just those 3 numbers on a single sheet of paper with the dates next to them. If they have moved upward even by tenths, even while staying inside the normal range, that movement is going to be the first thing your doctor sees when they walk into the room. The second thing is a single sentence written down so that you do not forget it under the pressure of the appointment. The sentence is this: I have been reading about the UVA research on long-term RAS inhibitor effects on renal arterioles, and I would like to ask about 3 specific tests. The third thing is the names of those 3 tests, also written down. The first test is called cystatin C, spelled Cystatin-C. This is a kidney function marker that, unlike creatinine, is not affected by your muscle mass, your activity level, or your age in the same way. It catches kidney filtration loss earlier and more accurately than the standard creatinine test, especially in adults over 60. It has been available in clinical labs for over a decade. Most doctors will not order it unless a patient specifically asks. The cost, depending on your insurance, runs between $30 and $80. Many insurance plans cover it when the indication is given. The second test is the urinary albumin to creatinine ratio, the UACRI mentioned earlier in the first half of this hour. This is the test that catches the leakage of albumin into the urine when the small arteries in the kidney start to fail. It is a single urine sample. It takes 30 seconds to collect. It is inexpensive. And it is one of the most reliable early signals of the structural change the UVA research is describing. The third test, if your doctor is willing to consider it, is a renal arterial Doppler ultrasound. This is an imaging study, not a blood or urine test, and it is the only one of the 3 that actually looks at the blood flow inside the small arteries of the kidney. It is not always ordered as a first step. But if your creatinine has been drifting upward, and if your UACR comes back elevated, and if your cystatin C confirms loss of filtration, the Doppler is the test that confirms what the UVA research describes. It is also the test that, if your doctor agrees to order it, signals that they are taking this seriously rather than dismissing it. Now, when you bring all of this in, here is what is going to happen. Your doctor is going to look at the printout. They are going to read your sentence. They are going to look at the 3 tests on your paper. And in the first 3 seconds of looking, one of 3 things is going to happen. The first possibility is that your doctor knows about the UVA research because they read circulation research, or because they read a summary in a medical newsletter, or because they have a particular interest in renal medicine. If that is the case, the appointment shifts immediately. They will say something like, "That is a good question. Let me think about which of those tests makes sense first." You will get the tests ordered. You will have a follow-up appointment. The second possibility is that your doctor does not know about the research specifically, but recognizes the names of the tests and understands why you are asking. If that is the case, they may ask you to send them the paper, or they may say they want to look into it before ordering, and the appointment will be set for a callback. That is also a good outcome. The pattern got broken. The doctor is now going to spend 20 minutes on their lunch break reading something they did not know about. And you have done them, and every patient after you, a quiet favor. The third possibility is the one we have to talk about, because it is the one that sometimes happens and the one that needs the most preparation. The third possibility is that your doctor reads your sentence, looks at the printout, and politely declines to order the tests. They will say something like, "Your numbers are fine, you do not need additional testing," or "That research is in mice, it does not apply to you," or "Your insurance will not cover that," or simply, "You do not need to worry about that." If that happens, here is what you do not do. You do not argue. You do not get angry. You do not get up and walk out. You do not threaten to find a different doctor. None of those will get you the tests, and all of them will damage the relationship you have spent years building with the person who knows your full medical history. Here is what you do. You say, in the calm voice of someone who has done their homework, one specific sentence. The sentence is this: I understand. Would you be comfortable noting in my chart that I asked about these tests today and that I declined them based on your recommendation? That sentence is the most important sentence in this entire video, because that sentence does three things at once. It is respectful, it puts the decision in writing, and it puts the decision in your chart where it can be reviewed at your next appointment and at the one after that, and where, if your numbers continue to move, it becomes a documented data point in your own medical record that you asked for this evaluation early and were told it was not needed. In almost every case, when a patient asks that sentence, the doctor pauses. They look at the chart, they reconsider. And often, they order at least one of the three tests, just to have something documented in the record alongside the patient's request. If they still decline, the request is in your chart. You have a record. And the next time something changes, your case has a documented history of having asked early. This is what it looks like to pull a doctor out of the pattern without breaking the pattern of trust. You are not fighting them. You are giving them new information calmly with citations, and you are asking them to either incorporate it or document that they have considered it. That is the conversation that gets you a different appointment. That is the conversation that, by the way, you can have at every appointment for the rest of your life about every drug, every test, every recommendation. The skill is portable, which brings me to the part of this video that, if you're still with me, is the part I made this for. I want you to picture something for a moment. This is the second of the two moments where I will ask you to do something with your body. The first one was to find those 3 creatinine numbers. This second one is smaller. Just sit back or stand up or do whatever you do when you want to feel slightly different than you did a minute ago. Picture yourself at your next appointment. The chair is the same chair. The cuff is the same cuff. The nurse who takes your vitals is the same nurse. Everything in the room is identical to the appointment you had 6 months ago or a year ago or 2 years ago. Same paper crinkling, same small window, same poster on the wall about flu shots. But something is different this time. And the something that is different is you. You walk in with a piece of paper that has 3 numbers and 1 sentence and 3 test names on it. You sit down, you hand the paper to your doctor before they have to ask you why you are there today. You say calmly, I have been doing some reading. I would like to ask about 3 specific tests today. I am not stopping my medication. I am not changing anything. I just want to ask, and in that moment, you have changed the appointment. Not because you became a different person, because you brought 1 piece of paper and 1 sentence into a room that for years you have walked into empty-handed. The doctor is going to react. The nurse, if they are still in the room, is going to notice. The next time you walk in, the energy is going to be different from the beginning. Your doctor will remember that you are the patient who asked. They will, for you specifically, be slightly more careful, slightly more thorough, slightly more inclined to think outside the pattern. This is not because you have done anything aggressive. You have done the opposite of aggressive. You have done something quiet and prepared and respectful. And the effect in a system that runs on patterns is to make yourself the patient the pattern updates for. Now I want you to take this 1 step further, because there is someone else in your life who needs to see this video. It is your adult child if you have one, or it is your brother or sister, or it is the friend you go to lunch with every Thursday, or it is the neighbor whose husband just had a kidney scare. Someone in your life is on one of these medications, has been on it for years, and has never once thought to ask any of these questions. They are still walking into the chair empty-handed. You are going to send them this video, not because you are trying to scare them, because what you have just learned in the last hour is the same thing they would benefit from learning. And the conversation you are about to have with them the next time you see them is going to be one of the most useful conversations you have had with them in years. You will say, did you know that the small arteries inside your kidney can change shape after long-term use of these drugs? You will say, did you know that creatinine is a lagging indicator? You will say, here are 3 tests you should ask about. And the person you love, who has been walking into their own chair empty-handed for years, will, the next time they sit down in that exam room, walk in with a piece of paper too. This is the identity, the one you are going to keep for the rest of your life. Not the patient, not the skeptic, not the person who fights their doctor. The person who reads the research before the doctor has time to. The person who walks in with one good question. The person who, at the family dinner, gets asked by the others what they have been reading lately. The person who has slowly become, without ever asking for the role, the medical reference point for the people they love. This is not a small identity. This is the identity of the person in every family, in every generation, who, when they are gone, is the one whose absence is felt at every appointment, every diagnosis, every conversation about what to do next. You can become that person in your family. The tools are in this video. The skill is portable to every drug on your counter, not just the one we have been talking about. The question, would you be comfortable noting in my chart that I asked, works for every test. The habit of bringing a single sheet of paper into the room works for every appointment. The shift is not from being uninformed to being informed. The shift is from being a person who waits for someone else to tell them what is happening in their body to being a person who walks in already knowing and asks for the data to confirm it. That is who you are now. That is the identity you walked into this video to claim, whether you knew it or not when you clicked the title. I am going to anticipate the 5 questions that are sitting in your head right now because I have been doing this long enough to know which ones come up most. The first question is, should I switch to a different blood pressure medication? The honest answer is, that is not a decision for this video, and it is not a decision for this week. The UVA research does not say that ACE inhibitors and ARBs should be abandoned. They are still excellent drugs for what they were designed to do. The research says that long-term users need additional monitoring beyond the standard panel. The conversation about switching, if it ever happens, is one your doctor leads after looking at your full picture. What you do now is ask for the tests. The tests inform the conversation. The conversation, if it leads anywhere, leads there in months, not in days. The second question is, how long is too long to be on these medications? There is no fixed number in the research yet. The UVA team studied patients who had been on the drugs 6 years or longer because that was the cohort they had access to. The structural changes were measurable at 6 years. Whether the same changes are present at 4 years or 3 or 1 is what the NIH grant is going to help answer over the next 4 years. What we can say now is that if you have been on a Pril or a Sartan for 5 or more years, you are inside the window the research has actually examined. Get the tests. Build a baseline, watch the slope. The third question is, what about other blood pressure pills, the ones that do not end in Pril or Sartan? The UVA research is specific to the renin-angiotensin system inhibitors. Other classes of blood pressure medication, the calcium channel blockers, the diuretics, the beta blockers, work through entirely different pathways and have entirely different long-term considerations. Some are gentler on the kidney. Some have their own issues. The point of this video is not that one class of drug is bad and another is good. The point is that long-term use of any drug in any class deserves the same kind of monitoring discipline. The skill we have been building, the printout, the sentence, the 3 tests, the chart documentation request works for every drug, not just the ones we discussed today. The fourth question is, what if my doctor has already retired or is hard to get an appointment with, and I have a new doctor I have only met twice? This actually makes the conversation easier, not harder. A new doctor has not built the pattern with you yet. They are still listening to you with fresh ears. Bring the printout. Use the sentence. Ask for the tests. A new doctor is, on average, more likely to order additional testing for a patient who arrives with a clear, specific, well-cited request, because they do not have years of habit telling them you are the patient who is doing fine. The fifth question is, why are you telling me this? What is your angle? The honest answer is, the discovery is real, the research is published, the gap between the discovery and the standard appointment is real, and the 4 years it will take for the guidelines to catch up is too long for a 66-year-old who has been on these drugs for 14 years to wait. The information was sitting in a journal called Circulation Research, behind a paywall, written in language that no normal person would ever read in their lifetime. What you got in the last hour is what is in that journal, translated. The angle is that the people in this country who could benefit from this information the most were the least likely to ever find it on their own. That is the angle. There is no other one. There is one more thing I want to leave you with. Everything we just walked through, the discovery, the imaging, the 4 warning signs, the 3 tests, the conversation script, the identity, all of it is, in the larger picture, one example of something that is going to happen again and again over the next 10 years. Here's the larger picture. A drug gets approved based on clinical trials that run, in most cases, between 6 months and 3 years. The data is good. The drug works for what it was designed to do. The drug gets put on the market. The drug gets prescribed. And then over the next 20 or 30 years, that drug gets taken by patients for durations the original trials never studied. 5 years, 10 years, 15 years, 20 years, 25 years. The drug is doing something during those long durations. Sometimes that something is benign. Sometimes that something is the slow, quiet, structural change that we just spent an hour talking about for one specific class of drugs. The truth that the UVA research points at, beyond the kidney and beyond the blood pressure pill, is that long-term effects of long-term drug use in older adults is one of the largest understudied questions in medicine right now. Which means that the medicine cabinet in your bathroom, the one with 5 or 6 or 7 bottles in it, is full of drugs whose 20-year story has not been written yet. Some of those drugs are going to turn out to be fine. Some of them eventually are going to have their own UVA paper written about them by a researcher who is, right now, in graduate school somewhere, looking at imaging that nobody else has thought to look at. The skill you just learned, the printout, the sentence, the 3 tests, the calm question, the chart documentation request, is not a skill that applies only to the blood pressure pill we talked about today. It applies to every bottle on your counter. It is the skill of treating yourself as the individual case you actually are in a system that, by structural necessity, has to treat you statistically. This is not a complaint about the system. The system is doing what it can with the time and the data it has. This is a clear description of where the system is limited and what you can do calmly and respectfully to fill in the part of your own care that the system cannot fill in for you. That is the larger pattern. That is the wider truth. That is what the hour was actually about, underneath the kidney and the pill and the research. You did not get this far by being careless. You did not get to be 60 or 65 or 72 by ignoring your body, by skipping your appointments, by refusing to take the medication you were told to take. You got here by paying attention, by following the plan, by being the patient who shows up and does what they are asked to do. And now you have one more thing worth paying attention to. One more piece of paper to bring to the next appointment. One more sentence to say calmly in a room where, for years, you have been the one who listened while someone else spoke. The kidney that is inside you right now is the only one you have. It has been working for you for every year of your life, including the ones where you did not think about it. It does not need you to panic. It does not need you to quit your medication. It does not need you to lose sleep tonight. It needs you to go look at your last 3 years of creatinine numbers. It needs you to write down 3 test names on a single sheet of paper. And it needs you to walk into your next appointment as the person you became while you were watching this video. If this hour has been useful, do one thing for me before you close the tab. Share it with the one person in your life who is also on one of these medications and who has never thought to ask any of these questions. They are walking into their own chair empty-handed. You can change that with one message. Thank you for spending this hour with me. I will see you in the next one.